Heather whether she was going to say anything about our conference, or whether I should say that first.
You should say that first.
Okay. All right. So if you haven't heard already, we have made the tough decision to postpone our second annual NCFS Caregiving Conference to the fall of 2022. So please, keep your eyes out for emails and check into our website frequently to see official updates. We're 99% sure it will be September 30th to October 1st. But keep your eyes out, and then we'll really ask people to be spreading the news about this. We are going to open up for new abstract submissions, just so we have the opportunity to get individuals who have new data that wasn't ready for our previous conference or our initial dates of the conference, to be able to invite them to attend as well. So keep checking in, and we hope to see everybody here in Pittsburgh in late September. For those of you who haven't been here before, we are the National Rehabilitation Research and Training Center on Family Support, or NCFS. We're funded by NIDLR through ACL, and our goal is to conduct research in caregiving, to facilitate rapid dissemination of research into practice, to train both family caregivers and healthcare professionals and researchers on family support, and finally to hopefully have an impact on public policy that's important to family caregiving. So part of our dissemination practice is to hold these monthly to bi-monthly seminar series. And today we're really happy to have one of our own, Scott Beach, who's going to be presenting. So Dr. Scott Beach is one of our co-directors for NCFS. He's also the interim director of the University Center for Social and Urban Research, where he's been the director of the survey research program since 1999. He's also he's also on the executive committee at the Center for Caregiving Research, Education, and Policy here at Pitt's Health Policy Institute. Dr. Beach has directed dozens of large-scale surveys covering a broad range of topics. And in addition to his work in survey methodology and research design, he has interests and has published in areas such as aging and caregiving stress, elder abuse, and technology and aging. His recent work in family caregiving has focused on the impact of caregiver burden and stress on the ability to provide quality care and potential neglect. He is the PI of our, what we call R1, one of our research projects that really is analyzing national data sets. And today he's going to be talking about this project. And the talk is titled Analyzing National Data Sets to Inform Policy and Interventions Regarding Family Support for Persons with Disability. This is, I think, is going to be really useful for us, for everybody on the call, about learning how to leverage really methodologically rigorous national surveys to examine family support and caregiving for persons with disabilities across the lifespan. So thanks for doing this, Scott, and we're really excited to hear about this work.
Okay, so Heather, did you want to, is it my turn?
It is your turn.
Am I good to go? Okay.
Yes.
All right, now I got to do a little manipulating here. Let's see. Okay, so are we still good, Heather? Are we good now?
Yes, we're good. We see the right slide.
Okay, thanks for the opportunity to do this. This is great. I know a lot of you on the call, so I feel like it's more like a sort of informal seminar among friends, but hopefully you'll still be friends after the talk. But I wanted to first slide here. I just wanted to acknowledge my co-workers or my collaborators, Rich Schultz, Esther Friedman, who's on the call, who's at University of Michigan, are the co-leaders. And this project would not happen without the three people at the bottom. And I believe Aileen's on the call, but Janet Schlarb, Chris Bream, who are data analysts, data coordinators, and Aileen Chow's our GSR has been doing a great job. Aileen has helped me put together a lot of the tables that you'll see today, at least the examples from tables that you'll see today. So I wanted to acknowledge those folks first. All right, so the outline, what I want to do today is I want to provide an overview of this project and some of the data sets that we're working with. I want to, as a background, I think it's good to talk about, probably most of you are familiar with this, but it's good to go over again, issues in the definition and measurement of family caregivers across the lifespan. And here I draw on a really nice chapter that Vicki Friedman and Jennifer Wolf I just found from 2020. There's some very nice summary tables. So issues in definition and measurement. The bulk of the talk is illustrative findings and data table examples. So these are just examples I'm going to show you of what we're doing from two key data sets that I've been kind of diving into. Other data sets, like Dr. Friedman is diving into some of the other data sets. We'll talk about that too, but these are the two that I've really delved into: the behavioral risk factor surveillance system caregiver module and the National Health and Aging Trend Study, National Study of Caregivers, of Caregiving, NHATS, NSOC. So I'm going to show you some data from those two studies. And really what I focus on are pretty basic questions here, at least in this presentation. How disability impacts health and quality of life of outcomes of persons with disability. So that's a person with disability analysis. Detection of family supporters and caregivers who are at risk or higher risk for their own negative health and quality of life outcomes. That's a caregiver analysis. And then how caregiving context, caregiver health, caregiver outcomes themselves impact their ability to provide quality care and potentially reduce or mitigate negative outcomes for the person with disability. So that's really like a dyadic level analysis. And then in conclusion, I'd like to discuss some potential policy and intervention implications. And here's where I'd really like some audience participation. I'd like to get your thoughts on how you might be able to use this kind of data. So the broad research questions and aims, I don't want to read all these on the screen, but these are from the project itself. This project R1 that Heidi mentioned in the National Center. And they basically mimic what I just the questions that I just said. The first aim is disability trends by demographics. I'm not really going to get into that today a little bit too much, but that's a disability analysis. Impact of disability on health is aim 2A. 2B is basically the caregiver and impact on their health aim. And then I actually cut through aim 3, A and B are these dyadic kind of questions about either having a caregiver versus not, or the quality, the caregiver's characteristics, and then how do they spill over to the care recipient, either in terms of care recipient health or their ability to provide quality care. And aim 4 is interesting. I wanted to have this on the screen to take a look at this. Our ultimate goal is to be informed on all these analyses we're doing, as well as some synthesis of the published literature based on these surveys. So I should mention, we want to disseminate key findings on family support for persons with disability, make recommendations on policies regarding family support, including recommendations for improving measurement and data collection strategies. So that's obviously something that this project could have something to say about. And so obviously there's been a lot of work done with these surveys. There's data out there. We don't want to reinvent the wheel, but I think what we're doing hopefully can add some value to the literature. I think in general, caregiving, lots and lots going on, but relatively few, surprisingly few kind of methodologically rigorous national level data sets when you really think about it. I mean, there's some, but there's not like a ton of really good national level surveys, especially those that are publicly available. That's the other thing I want to focus. These are publicly available data sets. So we know that like the AARP and the National Alliance for Caregiving do their caregiving in the US surveys, and they're often cited and it's good work. But it's generally, they generally don't make that data available to the public. So if you look on this screen, so the overall goal is to leverage these methodologically rigorous national surveys to examine family support across the lifespan. So that's the key. So on the screen, you see the data sets that we're kind of looking at. Behavioral risk, BRFSS and NHATS, NSOC are kind of highlighted there because I'm going to talk a little bit more about them. But you can see, and these are kind of ordered in the order of lifespan. So the National Survey of Children's Health covers children, of course, parents as caregivers. We have collaborators working on that. So getting some nice papers out of that data set. The American Community Survey is a massive survey done every year, basically replaced the census long form. So it's done every year. The interesting thing about this, it covers everyone 18 and up. They ask a question about grandparents as caregivers, which we're doing some work on that right now. It's very interesting. And you can actually, the sample size is so large that you can combine data on this ACS survey across years and get estimates down to like the county level. So it's a very interesting data set. The panel study of income dynamics is something that Dr. Friedman, Esther, is involved with. She's going to be our sort of go-to person for that. But this covers people 18 and older. It's a very interesting study. It actually recruited families in 1968. 68, that's right. And they've been followed for, and all of the people, their offspring and so forth. It's a very interesting family. It's a family dynamics kind of study. You follow people within the same family across many, many years. And there's some caregiving questions and ways you can get at caregiving that have been added more recently. And so you can get at some caregiver, care recipient within and across families over time. So there's some very interesting possibilities there. And we're going to be working on some of that this year. So the MIDAS is a midlife in the US study that covers basically midlife, 25 to 74. This one, you only can sort of get at people receiving care. So they're asked about help they're getting. So you can look at it from a caregiver, care recipient point of view. The health retirement study is another one that Esther is, Dr. Friedman is very familiar with. We've already done, this is one that covers people 50 and older, and you can sort of get at older spouse dyads, care recipient, caregiver dyads over time. We have a paper under review, hopefully will get published soon, looking at care recipients with and without caregivers and how that impacts their healthcare spending. So it's kind of interesting paper that we've done on healthcare spending. The National Social Health, Social Life, Health and Aging Project's an interesting one. It's basically older adults, mostly care recipient kind of data, but they do have some elder mistreatment questions, which is an area of interest to me. So it's a kind of good data set to look at. I've got some analyses on this one, attempting to link caregiving to perhaps elder mistreatment coming down the pike. And then NHATS, NSOC, which we'll talk about. So you can see that we're trying to cover, again, the lifespan with these data sets. We can't do everything with the data sets, but I think we're going in and doing some things that we think are interesting, have some policy relevance. So that's kind of like the overview of what we're doing. Now to talk a little bit about issues and definition and measurement, this is really based on, I basically lifted directly from it, several tables, but I think they're really good, nice ways to, I found these. These are actually referenced in the initial RAISE Act report to Congress. There's a link to this chapter, and I just found it very helpful. Changing Landscape of Family Caregiving in the U.S. by Friedman and Wolf. And it's in this larger volume on paid leave for caregiving by the Brookings Institution. So when you think about caregiving, there's lots of things around definition, conceptualization and definition. So family, we know that family can be broadly construed. It's not just legally recognized. There could be other types of relationships, biological step, adopted. The key is not familial relationship, but motivation by a familial commitment between the caregiver and the care recipient. Caregiving itself, how do you define that? And some issues around that. It's generally differentiated from normal exchanges or division of labor, like doing laundry, preparing meals, by its purpose. The tasks are carried out because of the recipient's physical or mental health or physical, cognitive, or sensory functioning. So it's requiring help because of poor health. We all know that the types of assistance can really vary. Caregivers do a lot of different things. It's more than just daily household chores and personal care. It's beyond ADL, IADL now. We know that caregivers provide social support, transportation, standby care, and there's this growing appreciation of the important role that family caregivers assume with like medically oriented activities and navigation of the healthcare system. And we'll see that the NSOC study has some good questions that get at that aspect, the medical and healthcare system interactions. Finally, you can have paid caregivers, and we talk about paid caregivers. They're either paid, you can have sort of more formal paid caregivers paid through Medicaid. Informal caregivers can also be paid, by the care recipient, by Medicaid. And paid caregivers and family caregivers typically assist with similar activities. And I think that's an area that we really need to start looking at, is how paid caregivers and informal family caregivers interact, and what are some of the dynamics there in providing care. So those are some of the issues around definition. In terms of needs for care, you often see these kind of slides, but I think this is a good organizing slide. People have different caregiving needs. It varies by the condition or the lifespan, where people are. So certain people, if you're managing a chronic condition with adequate functioning, so you're managing your diabetes, you really don't require caregiving. Some of it's short-term, things like injuries, short-term recovery from a joint replacement, maternal stuff, following a healthy birth. Then you've got more stable, significant disability like TBI, spinal cord injury that require long-term care. And then there can be episodic heart failure, depression, things that's episodic over the years. Short-term progressive things like late stage cancers, for example, would be short-term and progressive types of caregiving. And then I think when we think about caregiving, it's that last row we think about a lot of times, the long dwindling frailty, dementia, things that require long-term and progressive caregiving. So there's various types. Caregiving is complex, it's not one thing. This slide just shows, to give you a feel, to get you into it's a good lead in for some of the data I'm going to show, the various functions and roles that caregivers play. And it shows that it's obviously gone way beyond ADL and IADL assistance only. Caregivers serve numerous roles, attendants, providing the first two, the attendant and administrator, the household activities and self-care, what we typically think of, but they also provide emotional support. They're the driver. The medical roles and functions are interesting down below. This is what we're really starting to focus a little bit more on. This is sort of becoming part of the standard caregiving intensity, caregiving context kind of assessment. You need to find out exactly what the caregivers are doing, what kind of tasks they're providing, in addition to just simple ADL and IADL. So advocate, coaching, information interpreters, navigators, patient extenders, and so forth. So you can see some of those roles. Basically, healthcare interactions, medical care, transportation, and so forth. So caregivers are really asked to do a lot. We know that. And finally, just some more measurement issues that relate to family caregiving. So this really has direct implications for what you can get out of the various surveys. One of the keys is source of information. So I sort of already alluded to this. Caregivers may ask to be asked to self-identify. So you might have caregiver data. You're actually talking to the caregiver. Care recipients may be asked who helps them. Caregivers and care recipients may not consider the assistant's caregiving per se, may have different perspectives. So depending on who you're talking to, you may get slightly different data. The age of the care recipient is obviously important for lifespan work. Several studies focus only on caregiving for older adults, and that's what the NHATS NSOC does. It's the care recipients are all 65 and older, as we'll see. But some of the other studies have care recipients across the age range. The types of assistance measured or mentioned, the reason for assistance being linked. Some surveys explicitly link you're providing care because of a health problem. Others don't. They're more generic in how they define it. Time frame and duration. You can ask about current caregiving in the last month, last 12 months, current caregivers, former caregivers, and so forth. And then types of caregivers. Sometimes people will pull out what they call a primary caregiver, but that's tricky because caregiving is dynamic. It often involves networks of multiple caregivers, particularly in the context of more severe impairment. So it's kind of hard to find a primary caregiver sometimes. But these are dimensions and issues on which these various surveys, they differ. So you have to sort of dig in and see, how things are measured, how things are assessed that drives what kind of questions you can answer with each data set. Okay, so now I'm going to get into basically showing you some data, some of the stuff we're doing with the BRFSS and NHATS NSOC. So let me get into behavioral risk factor surveillance system for a minute. So this is an annual state level random digit dial population-based telephone survey, one of the few RDD studies I think that are still ongoing. It's repeated cross sections. It's not longitudinal. It's conducted separately by the state. It's got an interesting design with approximately 5,000 completed interviews per state per year. So you're looking at a huge sample size every year if you combine across the states. And there are core sections administered by all states with optional modules chosen. Unfortunately, caregiving is a module, and it was only added in 2015. I think Rich Schultz had some input into this caregiver module, helped design it. And it's not used by all states all years. That's the issue. So what we had to do, and few other people have done this, but we combined data from 2015, 2016, and 2017 across 44 states and the District of Columbia. So there's 6 states that have never done the caregiver module, basically to estimate a national sample with more than 250,000 total respondents. And if you look at that last bullet, we had that data set contains more than 54,000 caregivers. Now I gave it 1 exclamation point. I thought maybe I'd do 2 there because that's a really big number, but I didn't want to get too exuberant as a scientist, but that's a pretty big sample size. And when you work that out, that comes out to about a 21% prevalence when you think about caregivers and non-caregivers, which is in the ballpark from some of the other estimates. So huge sample sizes. We'll get into that in a minute. So caregiver screener asked during the past 30 days, do you provide regular care or assistance to a friend or family member who has a health problem or disability? Pretty straightforward. This is the way. So during the time frame's 30 days, regular care or assistance, and health problem or disability. Caregivers can be of any age. The problem, the downside in the behavioral risk factor survey is there's no restriction on the care recipient age, but the age of the care recipient is not collected. We don't know a lot about care recipients in BRFSS. What we do have in terms of caregiving context is they're listed on the screen. These are kind of standard. This is basically what's in the module. Duration of care, the relationship, hours per week. The main health problem, which is interesting, can also be a little bit tricky to measure. Presence of AD, cognitive impairment. And if you notice, BRFSS is a little older school. It's asking more just about personal care, feeding, dressing, bathing, and so forth, and household activities. There are no specific questions about medical care or healthcare interactions. But of course, the module, had to be relatively short, so there's always trade-offs. And then demographics are part of all these data sets. In terms of health and quality of life outcomes, in the BRFSS core section that everybody gets, self-reported health and unhealthy days. They ask about days during the last 30 days you were not good mentally, physically, or in terms of function. Healthcare access, coverage, difficulty seeing a doctor, health behaviors, and various chronic health conditions. Another interesting part, one of the interesting parts of BRFSS is they do ask the standard 6 question disability sequence. I'm going to show you that in a second. So these are common items that are used in a lot of these national surveys. For example, the ACS that I mentioned before, the large national survey, asks these questions too. So you can sort of compare across surveys and across populations. There's a similar set of questions by the Washington group that I think we're using in a current study we're doing on state of aging. They're basically similar, a little bit different, but these are the 6 that are in BRFSS that are used by ACS. So it's hearing, sight, difficulty concentrating, remembering. Look at the wording of number 3. It's kind of interesting. It's broad. Difficulty walking, climbing stairs, dressing, bathing. So, mobility, self-care, and then difficulty doing errands, visiting. So more like an IADL kind of functioning. So this is available in BRFSS for both caregivers and non-caregivers. So this allows the exploration of the intersection of disability and caregiving, something you don't often see. So caregivers themselves we know that sometimes they're in poor health. So this offers the opportunity to look at disability levels in caregivers versus non-caregivers, which we do. So this is the first table. Now, what I want to say before we get into any of the tables is, don't worry if you don't catch all the nuances of the tables. The point, and I'll share these slides afterwards, the point is to give you a feel for what we're doing. I think this table, so, I'm maybe to save time, I'm going to go fairly quickly through some of the tables, but I want to spend a minute on this one. And what I want you to focus on is that right column. So these are, I know that I mentioned there were 54,000 caregivers in this data set, and Dr. Schultz and Hansel and some of the folks on this call have been working with some of the subsets of folks in this data set. So it's amazing when you look, if you were really interested in really young caregivers, I mean, you could, from 18 to 29, you have nearly 4,000 caregivers you could look at using this cohort. So the numbers here, so there's the age breakout, female. If you were interested in, caregivers with less education, you've got almost 3,000 people that don't even have a high school education. So this really affords opportunities to dive into subgroups in a very detailed level, with a base sample, and then you can cross it with some other things to get smaller, but really, really amazing in terms of what the power of this when you combine across the states. And then this is a similar table, but it gets into some of the caregiver context groups, so you can sort of get a feel, if you're interested in the relationships, say you want to study parents taking care of a child, you've got nearly 5,000 caregivers that are reporting in the BRFSS across the 45, the country. 2,200 and almost 2,300 grandparent caregivers. So, some of these groups that we know are high risk, people providing 40 or more hours of care, you've got over 9,000 of those folks in this data set that you can look at as a subset. So, and then of course, the types of the conditions, if you're interested in, like I've been doing some work on caregivers of developmental disorder, mental disorders, substance abuse, mental illness. There's more than 4,000 caregivers you can look at in this data set. So very powerful data set. That's probably its main strength, the sample size. All right, so to get to some of the basic findings, I mean, some of this stuff is not going to be, it's going to be kind of intuitive, but it's good, I think, to go through and show it. So in terms of how disability impacts the quality of life and health of persons with disability, we see, unsurprisingly, that persons with disability, and when we say that, we mean any of those six, I'm kind of talking in general, saying yes to any of those six disability items, consistently reported poorer health and quality of life than those without disability. And again, remember, this is cross-sectional, it's a snapshot. We cannot really say anything about causality. Keep that in mind, these are all associations. So everything I'm going to present today is cross-sectional. We're obviously working on some longitudinal analyses, but as a basic presentation, I wanted to show some bivariate, some cross-sectional findings. So persons with disability are more likely to report poor self-rated health, unhealthy days, poor health behaviors, chronic conditions. Makes sense. Disability is typically, people have chronic conditions. These findings do replicate when you examine each of the six types of disability separately. So in other words, if you look at any one of those questions, you still get these effects, these differences. The people who report disability have poor health than those who don't. In terms of detection of family caregivers at risk for their own negative health outcomes, the first thing I could say, this is a study that gives you the opportunity to do the old caregiver, non-caregiver comparison. And you could do this in a more sophisticated way. You could do some kind of, I thought about propensity matching. You could find 50-some thousand non-caregivers that look more like the caregivers. And I'm thinking about maybe some approaches to doing that, some matching, some match samples. But this is just a rough basic comparison of the caregivers and non-caregivers, everybody in the sample. The caregivers consistently reported poorer health and quality of life outcomes than non-caregivers. So that's not surprising, I think, to the folks on this call. And here I did do some multivariate modeling with the BRFSS. So basically controlling for demographics, caregiver associated demographics, and they're listed in the paren there. In multivariate models, caregivers are more likely to report, and you can see the list: poor self-rated health, unhealthy days, being unable to see a doctor, smoking, some of the chronic health conditions. And very interesting, the last bullet, caregivers are more likely to report disability than non-caregivers. So in terms of any disability, about 30% of the people identifying as caregivers said yes to one of those 6 questions versus 23% of the non-caregivers. And difficulty walking, climbing stairs, and difficulty concentrating, remembering, and making decisions came out when you looked at them separately. So those are caregiver and non-caregiver differences that hold up when you control for sociodemographics. All right, so here is the first sort of example of a table, the kind of things we're working on in this project. We've got these tables basically for all the outcomes, all the across the various aims that we talk about. When a study can address a certain aim, we're creating tables. And so this table shows for this 2015-17 BRFSS cohort, the caregiver and non-caregiver comparisons across basically all the health, quality of life related outcomes that are available in BRFSS. And checking the time here, and the multivariate model. So if you see the percentages are shown, so you can see caregivers, about 20% report for poor or fair health versus 17% of the non-caregivers. Large difference there on the mental health, not good for, and I just happened to cut this at 4 or more days. There's other ways to cut this, but 31% of the caregivers report that versus 21%. The far right column shows the odds ratios for caregivers versus non-caregivers from a logistic regression. And it shows basically the stars are showing you where things are significant. Basically, the controlling for all these things, caregivers, for example, have a 63% higher chance of reporting more poor mental health, 4 or more poor mental health days in the last 30 days. And they are more likely to see almost 50% more likely, 54% more likely to not be able to see a doctor because of the cost versus a non-caregiver. So you can see a lot of different, and caregivers have a lot of the more higher levels of chronic conditions. So we're seeing in this data set that caregivers themselves are in poorer health than their non-caregiver comparison group. So that's an example of the kind of table. And you can see the garish colors that I put in there. Basically, I'm highlighting areas in orange where there's a sort of a larger effect. The yellow is kind of more, in this data set, less than 0.01 is kind of considered a smaller effect given the sample size. And then, of course, these are larger effects in orange. And then the caregiver being highlighted up there in orange shows that that's sort of the group at risk. So we're trying to make these tables look a little more readable. Things jump out. You'll see some of this in the NHATS, NSOC, the way I'm structuring the tables. If people would look at this, they could get a quick feel for what's going on. So in terms of, so that data was just showing that caregivers are more likely to be disabled and report poor health than non-caregivers. So then we get into, within the caregivers, what are the high risk subgroups? What caregivers do we need to pay attention to? And again, we've seen a lot of this in the literature, but it's kind of cool to go into a large data set like this and confirm this and do the analysis. But you can see some of the high risk subgroups. The first set is sociodemographic, and the second set down below is caregiving contextual. Some of these, older age, minority, less educated, low income people, caregivers generally that don't work are in kind of worse shape than those that do, and there could be a variety of reasons for that. They're not able to work. Caregivers living alone have a little bit more problems. People who are more into higher intensity caregiving, you can see down below, longer duration, providing more hours, spouses and adult child and non-relatives versus other types of caregivers and so forth. And caregivers of certain disease groups. Now, if your favorite disease group doesn't show up here, that doesn't mean that caregiving for that group isn't stressful. It's just that these are the ones that kind of jumped out when we did some comparisons: arthritis, asthma, AD, ADRD, diabetes, and mental illness. And so these are the sort of at-risk subgroups. So to do this kind of work, this is an example of another table. This is the working, non-working caregiver comparison. This is within caregivers, showing those not working versus those working, and doing a similar kind of analysis where you can see a lot of the people not working have a lot more chronic conditions, and makes sense. It probably prevents them from being able to work. So we have to think about causality, but you have to keep that in mind. We think about working caregivers being stressed, and they are, but in general, people working, there's kind of a protective effect for that. And we're seeing that in and a paper that Hansel and Rich and I and some others are working on sandwich generation caregivers. And again, you see the multivariate. This is working versus not. So you're seeing a lot of odds ratios less than 1. So they have a lower probability. The workers have a lower probability of having poor health. And finally, in terms of BRFSS, when you think about caregiving context and care recipient outcomes, you can't really address this. And this is, I'm going to put this slide up. It's like my last bullet. There's no dyadic data in BRFSS. You can't address all the questions with each data set. That's kind of a basic point I wanted to make. So there's really no way to kind of do this. We don't know really anything much about the care recipient in this data set. All right, let me move on to NHATS NSOC. So this is a nice sort of dyadic study. The NHATS itself is an annual, it started in 2011, it's ongoing, in-person interviews with a nationally representative sample of Medicare beneficiaries age 65 and older. So you've got an older adult population. It's a longitudinal cohort panel design. There's detailed assessments of health, disability, you can see sociodemographics, housing, well-being, and so forth. One of the key features here is they ask care recipients, especially those who need help or have difficulties with ADLs, IADLs, and mobility, if they have unmet needs that lead to adverse consequences. Like in the last month, I couldn't have a hot meal because I didn't have anyone there to help me cook. I had soiled clothes because I didn't have anyone to help me with my toileting. So this is a good quality of care indicator. I've used this in some of my studies, so it's kind of unique. The caregivers are located through the older adult participants. So there's roster methods. So if the care recipient says, yes, I received help with mobility, there's a household roster, and they sample from that. This is who provides care. It's my spouse, it's my daughter, it's my son, it's my brother. Then those people become eligible for the NSOC study. So it's kind of located through, it's kind of a different way. It's an interesting way to locate caregivers. So again, this allows for these dyadic caregiver care recipient analyses. And here you can see some of the more detail on the quality of life outcomes for care recipients in NHATS. We don't need to spend a whole lot of time here. Social participation restriction. I know that in disability, people talk about participation restriction a lot. I should mention that this is kind of a limited measure of it. It's 4 activities, and they're really like, so I don't have it right in front of me, but it's like going to see friends, going to religious services. It's basically social activities, and they count up the number of important activities which caregiving kind of makes it harder to do or keeps them from doing. So it's not full participation in life, it's social participation. So hospital stays, falls, depression, anxiety, general psychosocial well-being scale, an item on sleep quality and the adverse consequences. In terms of disability, this is kind of interesting. One of the things that NHATS does, I think it's interesting and valuable. They have created a pretty innovative behavioral adaptation disability continuum. And this is across 11 ADL, IADL mobility tasks. So they ask, whether you can do it or not, but they also ask about use of assistive technology, environmental modifications. I'm not going to get into the details of how they do this, but basically they come up with this 4-level scheme that they've published and validated. Someone can have no limitations, be fully able, that's like the control group. Successful accommodation, that's kind of interesting. So people have a limitation, but they successfully accommodated it through assistive technology or environmental modification. Group 3 is that they're having difficulty. They're not getting any help, but they're still having difficulty even with assistive technology, environmental accommodation. And level 4 is people that just basically have to get help, receive help from another person to perform the task. So NHATS is kind of interesting. It's not just yes or no, do you have disability? It's kind of this continuum. We'll see some interesting results there. Okay, so just switching to NSOC real quick. So NSOC, again, is a telephone interview. The NHATS is an in-person annual interview. The NSOC, where the caregivers are found through the NHATS participant, are telephone interviews. I think they average about 30 minutes, so it's a shorter survey. There's about 2,000 caregivers, maybe a little bit more per wave, so a lot smaller sample size here than BRFSS, but it seems like a lot richer data set. That's one of the things you find with this data, or these various surveys. This was done in 2011, 2015, and 2017. But in 2015 and 17, there's a longitudinal, certain caregivers were interviewed both years. We have not, I'm looking at some stuff right now. I'm not presenting any of that longitudinal data today, but we're looking at some of those analyses right now. The assessments are less detailed. It's a shorter interview. And you've got detailed caregiving context, which I'll show you. So I'm gonna keep moving here. So this is just what's available. Caregivers can be of any age, but the care recipient is age 65 and older only. So that's one thing. This is caregiving for older adults. You can see here some of the contextual variables, a little bit more than in BRFSS. What I want to point out is down there, they do ask questions about helping with medical care and helping with healthcare interactions. So it's a little more detailed assessment of what the caregiver is doing. Affords some interesting analysis opportunities. The quality of life and outcomes are similar to some of them parallel the NHATS. I don't want to spend too much time on that. The only thing different here is you've got caregiving impacts on employment or work we're looking at, and also a caregiver burden, something that's specific to caregivers. But the others are kind of similar to what's measured in NHATS. So to get to some of the results, this first question about how disability impacts quality of life across health and quality of life outcomes. Older adults who receive assistance or help from another person have the worst, most negative health quality of life outcomes. It's kind of interesting. So those who need help or are getting help are the worst off. And basically you see this gradient, this negative outcome gradient across those four categories, such that those receiving help are worse off than those reporting difficulty but not having help, worse off than successful accommodation, who are worse off than people with no limitations. And so this is an example, and I don't want to spend a lot of time. In the interest of time, I'll go quickly, but you can just see this is the gradient across some of the outcomes. This is the NHATS care recipient data. So if you look at participation restriction, 2 or more of these 4 activities, people with no mobility limitation, only 1%, very few are restricted, 5%, 9%, and up to 29% of the people receiving help, getting assistance, are reporting 2 or more participation restrictions. And then you can see the gradient across some of the other outcomes, hospital stays, falls. So that's kind of not surprising, but I think the gradient is interesting. In terms of subgroups, some of these we've seen before. There's a lot of detail on the slides. I'll share these slides. What I wanted to do was I highlight the groups that come out as groups at risk. This is sociodemographic factors. We've seen some of this before in some of the other work you've all done. It's interesting. You get both the less educated are more depressed, have poor psychosocial well-being, physical health symptoms, and self-rated health, whereas more educated caregivers report more social participation restriction. So it's not just same for low and high income. The higher income, low income, we think of as the risk factor group. But in this data set, people with high income are actually reporting more work impacts and more participation restriction. And the last bullet is kind of interesting. Dual eligible, we pulled out. So this is the caregivers can be of any age. So basically, if the caregiver is 65 and older and also has Medicaid, they're dual eligible. So that comes out as a group that is really at risk for a lot of these negative outcomes for caregivers. Has some policy implications. And we see again, not working for pay. So I'm going to just show you one of these tables, and I'm going to skip through the rest because in the interest of time. But this is the way the tables from NHATS NSOC look. And again, just to get oriented, this just shows an example. Caregiver depression and anxiety is the outcome there at the top by caregiver sociodemographic. So this is an NSOC caregiver analysis. So it's showing you basically, if you look on the left, you can see kind of which factors, yellow means 0.05 and then orange is 0.01. And then I highlight the groups that are more at risk. You can see, you go down the line, not working for pay, dual eligible, and the numbers are over to the right. So this is an example of some of the kind of tables we're pulling together across all the outcomes, all the predictors and so forth. In terms of caregiving contextual factors to put people at risk, again, some of these you've probably seen, daughters, spouses, co-residing, providing high levels of care, high levels of personal care, mobility, medical care. It's interesting that providing, these are yes, no questions. There's several things. I just created a yes, no on medical care and healthcare interactions. Are they doing it or not? Those who are performing medical care activities have negative outcomes on all of the outcomes. It's the most strong. So that seems to be really important. So doing things like shots, injections, taking care of medical things really puts the caregiver at risk for higher burden, depression, variety of problems. So there's a table showing that. I'm going to skip that. This is participation restriction by the context variables. You can see kind of how that comes out. And third, I think this is some of the more interesting stuff. This is the contextual, the dyadic analyses. How do caregiver factors relate to care recipient outcomes? And notice I say caregiving contextual factors associated with, so keep in mind, it's really important here. Keep in mind, we don't know anything about causality. These are correlations. You can see it going both ways. So this is contextual factors that relate to negative care recipient outcomes. And I think, so the second bullet, so daughters have care recipients with more adverse consequences, unmet needs. People providing high levels of care also have, you might think this is counterintuitive, but the more care they're providing, the more likely the person is to report unmet needs and adverse consequences. Or they have care recipients that are depressed. So again, high levels of helping with medical care is related to having a care recipient that reports unmet needs and a care recipient that's depressed. So these are kind of going across the dyad. And there's a table showing some of that. I'm going to skip that. In terms of mental health factors associated with poor care recipient outcomes, I've done some work, this first bullet. Caregivers with high burden have care recipients who report lots of unmet needs, more likely to report falls, depression, anxiety, and poor social cycle well-being. And you can see the last two bullets, some interesting work out there showing like what they might call emotional contagion. When you have a caregiver with high depression, you're more likely to have a care recipient with high depression, high anxiety, poor psychosocial well-being. And the same thing comes out for anxiety. So anxious caregivers have depressed, anxious, and care recipients is kind of what is coming out of this data. And there's a data table showing some of that. This one is caregiver stuff is the rows, and then care recipient outcomes across the top, as you can see. And finally, there's some various health symptoms that are physical health symptoms that were asked of the caregivers. Things like breathing problems, upper extremity, lower extremity, low energy, pain. Some of these come out. It's interesting. Some of these factors also associate with poor care recipient outcomes. So if you have a caregiver reporting fair or poor self-rated health, the care recipient has more hospital stays, anxiety. I think some of these, again, the causality is not clear, but one that's really interesting to me is that third bullet. You have a caregiver who reports upper extremity limitations. They have a care recipient that's more likely to have fallen. So I think that sort of indicates the inability to provide that, the ways that caregiver physical symptoms and disability can impact their ability to provide care. So these are pretty interesting. So you're seeing physical symptoms in the caregiver relating to negative outcomes in the care recipient. All right, I see that it's about 10 till, so let me get to what my conclusions are and some potential policy and intervention implications. So I threw a lot of data at you. There's a lot of tables, but it's meant to be more illustrative of what we're doing, getting sort of basic handle on a couple of these data sets. But I think, what this work could really help do is, obviously pull out subgroups that are at risk for potential intervention targeting, providing detailed portraits of subgroups and risk factors that might inform intervention strategies. So you think about something particularly like the large BRFSS subsample sizes, and you can go in and really dig into a subgroup you're interested in and kind of learn more about the dynamics of what's going on. The complex dyadic longitudinal NHATS NSOC design, the elegant design affords a lot of opportunities. The panel study of income dynamics and health retirement study. You've got detailed longitudinal dyadic financial data, which really could impact. You can do some nice policy analysis. The ACS, very large sample size, data at the county level for place-based analyses, grandparents as caregivers, all kinds of opportunities. We eventually want to make these data tables and some kind of summary of caregiver survey resources are going to be released publicly as part of this project. That's one of the products. And I think some of the tables are probably getting close to being able to be shared with others. They're in decent shape. That needs some input. In terms of policy, I mean, obviously that relates to interventions, but doing policy relevant caregiver group sub-profiles, or subgroup profiles. So those with paid caregivers, those without, dual eligibles, low income caregivers, understudy groups like grandparents, siblings. I'm actually working with Melanie Hughes right now to do some profiles of various caregivers across the lifespan in terms of sociodemographics, some of the outcomes. She's going to do a series of policy briefs, I think, based on some of this data, potentially informing implementation of some of the RAISE Act recommendations, including engaging caregivers as partners in long-term services supports, service supports for caregivers, and financial and workplace security. Some of the RAISE Act stuff I think this is relevant too. And then direct relevance to this RAISE Act recommendation on establishing a national data infrastructure. So obviously this is good for that. So, all right, I guess it's 5 till 12. I haven't left much time for discussion or questions, but I could stay a little bit later if folks want to, but that's it for me. So questions, comments? I'll keep the slides up in case anyone wants to put that slide up.
Thanks, Scott. That was that's great. One thought that I came to based on your presentation was the possibility, given the way you were approaching the data, and particularly in NSOC and NHATS, of doing something that I don't think has been done before. Maybe I'm wrong, but we tend to focus on risk at the caregiver and care recipient level. What your comments today suggest that it might be really interesting to develop a risk profile based on DIATs, the two of them together. So
right. Definitely.
That's I think that would be a potentially very interesting paper to, and you've already got, some of the data you presented already points, gives some hints as to what that's going to look like.
Yeah, right. I thought of it more. I've often thought of it as a quality of care issue, that if the caregiver's factors and health and quality of life impact their ability to provide quality care. But it really is, you're right, it's like a dyadic kind of situation. Mm-hmm. And there could be things going both ways. The care recipient being depressed and anxious is certainly going to make the caregiver feel more burdened. And right. Yeah, the dyadic stuff's very interesting.
Hey, Scott, this is Kelly Schaefer. I'm calling from University of Virginia.
Oh, hi, Kelly.
Hi. I just wanted to say thank you. This data is so fascinating, and I really thought that I knew what data sets were out there, and you've opened my eyes to a lot more that's available. And I really think, as far as like intervention implications from this, I found that a lot of the work that you and your teams have done in the dyadic analyses, that's inspired some of my work. I really think that showing that what we do for caregivers and how caregivers are functioning directly impacts how patients do is really like the argument for getting interventions for caregivers implemented, which it sort of rubs me a little bit the wrong way, because we should care for caregivers for themselves. But I think that this is so important for getting these interventions implemented when we do know that there are limited resources. From a really selfish question, did you happen to look, or were there, you mentioned that NHATS had sleep quality data. Did you happen to look at the relationship between patient and caregiver sleep, or care recipient caregiver sleep?
Yeah, well, it's in one of the tables. I don't have it in front of me. I just didn't pull that part out. But the issue is the sleep is only measured by like 1 or 2 questions. It's a little tricky.
Sure.
It's not as,
Yeah.
it's almost like you have trouble falling back asleep. Some of them are more related to caregiving. There's not a lot of sleep stuff in there, but yes, I think I can say that one of the tables does have, caregiver sleep on the one side and then care recipient sleep on the
Awesome.
other. But I'm not
I'll
sure
go
if there's a
back and look
relationship.
at that.
I don't recall if there's a relationship or not, but we're looking at that. Yeah, so like
Awesome.
it's kind of a systematic approach. All those things that I laid out, they're crossed with all the others in the table. So there's a set
That's
of tables,
great.
and that's where Aileen and Janet have really helped me put together a lot of those. And I think I just see them as a resource to kind of go in and look at where relationships are and think about, it might drive ideas for.
Totally. Yeah, that's so helpful to so many of us.
But anyway, yeah, thanks for your comments. Yeah, I think the dyadic stuff, obviously we want to take care of caregivers. I mean, that's the whole, we want to make sure they're okay, but if they're not, then the implications for.
happens?
So,
Yeah, it shows the trickle down.
but I can look at if you want to send me a note, I can actually let you know. I can look at the data and answer your question.
Yeah, that sounds awesome. I'll follow up. Thank you so much.
Sounds like another good UVA Pitt collaboration.
Yes, I actually just slacked one of my collaborators on the side who does a lot of smoking cessation. And I was like, we got to do this too. So I'll throw that in there as well.
Hey, Scott.
Any other?
I have a quick question.
Hey, Beth.
Nice presentation. I learned a lot more about other data sets that I wasn't aware of because from my postdoc days, I really only knew of NHATS and NSOC, so this is great. I'm curious if anyone on the call knows whether or not the training items that are part of NSOC NHATS are going to be expanded upon in subsequent revisions or surveys that are asked in the future phases, because I mean, I think, from that one article that was published from collaborators at Johns Hopkins, they found that it was over 90% of caregivers reported feeling very unprepared and receiving no training.
Right.
So I'm just curious with knowing that item that's on NSOC, it's did you receive caregiver related training? Yes or no? Is there talk about diving a bit deeper and trying to understand what training means?
Question.
That's a very good question. And you raise that's one of the things we haven't included in the tables yet, which we may want to think about including receipt of training. So remind me, Beth, it's a single item, right?
Yeah, and it's not associated with any specific care settings or provider types. So I didn't know if the developers of these national data sets have started talking about that section.
They certainly will, I think. NSOC, I think that has not been expanded as far as I know. I think that NSOC actually, was done again in 2021. I know that NHATS is done every year. And I believe that 2017 was the last one we're presenting, but I think there's new data coming out in 2021. And I don't think, they've added some sections on healthcare interactions and things like that. There may be some questions in there about that. I have to look, but I'm sure that's going to become more of an issue, I think moving forward. I think some of these surveys have to start tapping that. I know that the NAC surveys, the Caregiving in the US kind of surveys get into it a little bit more, but those aren't generally publicly available, but you can probably, but I don't know, Rich, do you know of any other surveys or anyone on the call that are looking more at training receipt? I don't.
Not really.
Yeah, see, that's what.
Maybe the NAC may have a little bit more data, but I don't recall. It's a great suggestion though. And one would hope that the developers of these surveys, as they move to a new wave, they review what they've got and make some adjustments to reflect what people might be interested in, what's important. So it's a great idea.
Yeah, they do that. They're adaptable and flexible. These surveys do add and remove things, but yeah, that's a good one.
Yeah, I was just curious if it was part of the discussion for the RAISE Act and the establishing a national data infrastructure.
I think it could be coming,
Yeah. Okay. I haven't been doing a great job of keeping up with the recommendations from the RAISE Act, so I just didn't know if there was something recent related to that. So thank you.
Sure. Good question.
The RAISE, they did hold their most recent meeting of the RAISE Advisory Council, and are looking really to put out the report, I think late summer, early fall. So they're doing some subcommittee meetings on building the strategy. But I didn't, Julie, I don't know if you remember hearing direct discussions about national data set contributions. I don't think they spoke specifically to that.
No, I mean, I guess that's where the rubber hits the road, because it'll be one of the aims, but we don't know who's running, you know, who's driving
Yeah.
it.
Yeah, exactly.
Well, it's a little
Yeah.
after 12. I want to be,
Yes.
you know, I'm going to be respectful of people's time. I don't,
Yeah.
I can certainly stick around for a couple minutes if people have more
Okay.
questions.
We certainly want to thank you, Scott. I mean, I think this is going to be one of the really most fruitful projects, you know, in terms of creating this shared resource. And, you know, I look forward to a lot more conversations about how we make it
Yeah, it's,
accessible and,
it's,
you know, the best ways to support other people using this data to advance the science.
yeah, it's challenging. You know, I kind of bit off
Yeah.
a pretty big,
Yeah.
because I never learned. I bit off a big project, but
Yeah.
I think, you know, with Esther and Rich's and all those, Janet and Chris and Aileen's help, we can, you know, may not get everything done, but I think we can get a nice product out. Technically, the
Yeah.
project ends at the end of this year, so I'm really kind of in
Mm.
done mode, you know, get some,
That's right.
some product out. So, well, I appreciate the
Right.
comments. So if anyone else has any follow-up comments or questions, feel free to email me personally. I'm gonna have Heather and Julie, whoever, or circulate the slides so you guys can have those. Take a look at the tables a little bit more. Than the tables, Rich, you know, I think you and I should look in more detail at some of the stuff we're doing, and you know, you can provide feedback, or the group, the internal group, can provide more feedback. I'll post revised versions of those up in the share area, so our group can sort of start really looking at what we're
Well,
doing.
I think, Scott, that Esther, you and I ought to maybe have a conversation soon about doing a paper that sort of presents this overview, you know, in the context of what has and hasn't been done by other people.
Yeah, there could be like an overview paper. Yeah.
Yeah,
Okay.
I think this would be very valuable to the caregiver research community.
Okay.
Yeah, I
All
like
right.
that idea. The unique contributions of the different data sets. Because
Yeah.
as Scott showed, you can't do everything with every data set.
Okay.
Yeah.
Thanks, everybody.
Great.
Let me stop sharing. There we go.